Thank you, Dr. Austin. It's a pleasure to be following Dr. Bloom's talk. It was actually my fourth-year medical student rotation in Ann Arbor with Dave that was the initial inspiration for me to go into pediatric urology. So thank you for that, Dave. I appreciate it. I'm really honored to have been asked to moderate this session today. Good morning, good afternoon, good evening, whatever time zone you're in. We have three excellent panelists today. They are among a really growing group of mid and early career urologists who have taken a real passionate interest in pediatric urological oncology, which is really heartening. I think there's been concerns over the decades about pediatric urology losing their footing in that area, and that's really there's been a good resurgence lately. I think it's really important for our field, but also important for the patients that on an individual level at our hospitals, and at a larger level in the planning of institutional studies and surgical guidelines, that the pediatric urology perspective needs to be heard. So I'm really thrilled that there are so many people that are interested in this field. The plan for this session is that I'm going to introduce our speakers briefly. For each of them, I'll post a few questions or thoughts, the issues that I think about when I think about their topic that I think they will largely address in their talks, and if not, we can discuss in the case session or in the Q&A afterwards. And then each of them will give their talk in turn, and then we'll have some time for some case presentations. The Pediatric Urology Oncology Working Group of the Society for Pediatric Urology sent out an all-call for folks to send in interesting cases. I really appreciate the response. There was an overwhelming response. Obviously, we're not going to be able to show all the cases that were sent, so I want to thank everybody who sent cases. The cases that we do present, I will definitely acknowledge the folks who sent the cases. I've even kept them in the format of their institution. I did tweak things a little bit for brevity and occasionally change the cases a little bit in order to focus on a certain pedagogical point. So anything that's wonky about the cases, definitely blame me. Anything that's really cool about the cases, definitely give credit to the folks who sent them in. So let's get on to our speakers, and then we'll have Q&A after that. So I asked each of our speakers to send in a photo of them doing something fun, so you can garner a little bit of information about them just from the photo that they choose to send. Jonathan Ruth comes to us from Duke University, and he's going to be talking about the role of retroperitoneal lymph node dissection in paratesticular rhabdomyosarcoma. So when I see these patients, there's a couple things that come to mind. The first is who needs retroperitoneal surgery. In the clinical stage 1 patients, who needs a staging lymph node dissection? I think where most of us are familiar that age is a clear factor in that. I'm sure John will touch on that issue, but are there other things that are important as well? And what about the patients who have positive lymph nodes on CT? What's the role and type of retroperitoneal surgery there? And sort of a theme with both of the first two talks will be what retroperitoneal surgery should be performed. Anybody who's getting retroperitoneal surgery for whatever reason, do they need a bilateral, full nerve-sparing RPLND? Is there still a role for a modified template? Are there certain cases where really all you need to do is a biopsy or excision of a node? So we'll cover those. I'm sure John will touch on those subjects, and we'll cover them as well with the cases. Candace Gramberg comes to us from Mayo Clinic, and she is going to be speaking on RPLND and adolescent germ cell tumors. I think whenever we talk about adolescents, there's always the question, well, should we just do what we should do for the adults? And in this area, there are AUA guidelines, but there are other cancer group guidelines that may differ somewhat. So there's some question, even if we're going to do what we would do for adults, what does that mean? And then specifically for RPLND, there's really two situations where this has a role for these patients, at least this in the way I think about it. One is before chemotherapy. In order to stage those who are clinical stage 1, and maybe it has a therapeutic value as well, and maybe even a role in the clinical stage 2 patients who have limited disease. The other time that this comes up is after chemotherapy. There was a retroperitoneal mass, they've had chemotherapy. Do they need an RPLND to deal with what was a mass? What are the indications for that? And again, which operation do you do? Do you just excise the mass, or do you do a fuller RPLND? Finally, Amanda Saltzman, who comes to us from the University of Kentucky, will be talking about the role of testis-sparing surgery. I think we all know that this is becoming widely accepted. I don't know if it's the gold standard, recommended, an acceptable alternative. Maybe she'll address that issue. And I think if we are convinced it's a yolk sac tumor based on AFP, we would all agree to take out the testicle. Does that mean everyone else should have testis-sparing surgery, or do you take into account other findings on the ultrasound and so forth? So who are the candidates? Would you ever consider testis-sparing surgery in an adolescent, in something that really looks benign? Do we really have to take out the testicle? And even in cases, those rare cases of a malignancy, if there's a solitary test or some other extenuating circumstance, should we consider testis sparing in those cases? And then there are a few issues regarding technique, which if Dr. Saltzman doesn't cover in the talk, we can sort of discuss in the sessions after that. So I will stop my talk there, and I will turn it over to John Ruth, who is going to give us the first of our 10-minute talks.
Okay. So thank you all very much for the opportunity to speak today to Dr. Luis Braga and everyone for putting together a fantastic program. It's been quite a day. In terms of disclosures, I should mention I'm a member, as many of us are, of the Children's Oncology of various committees. These views that I'll be talking about today are not necessarily those of COG, they are my own. I have no other financial conflicts of interest. Given that it is after 5 p.m. on a Saturday, I do feel obligated to disclose that I have been wearing pants all day and still am. But other than that, I think that's about the only disclosures to mention. In terms of overall kind of what I'm hoping to hit on today, first and foremost, some general principles for surgical management of randomized sarcoma. We'll talk briefly about what the current data shows, what current experts say, and then lastly, I'll finish up by simply going over what I do for my own patients in these situations. So, as everyone is aware, sarcoma staging depends on both tumor biology and on the surgical management of the individual patient. We wind up with low, intermediate, or high-risk groups depending upon that combination of factors. And risk group ultimately depends upon the stage of the tumor, which is predominantly based on both the size of the tumor, is it greater or less than 5 centimeters, but also upon the location from which it arises. In the case of para-testis randomized sarcoma, that is considered to be a favorable site, and therefore these patients in general are going to be stage 1, so long as they're relatively small to begin with. Group is really where the surgeon plays a role, because here it depends not only on the spread of disease, but also on the actual completeness of the resection. And then also on the cancer type. Is this a fusion protein producing tumor and non-fusion protein producing tumor, previously known as embryonal or alveolar tumors? And again, as I mentioned before, almost all para-testis rhabdos are going to be low risk because in general, they're picked up relatively small, typically, and in general, they are arising from the para-testis region. And so because they are low risk, there's relatively low value for these patients for either a pre-tumor excision or a delayed primary excision, either one. This is really kind of one of the fundamental things that we need to chat about, which is ultimately what are the goals of randomized sarcoma surgery? And ultimately, there's really two things we're trying to accomplish as surgeons here. First and foremost, we're trying to establish a diagnosis. We want to get information. What exactly is this tumor, which appears to be, arising in this case from the para-testicular area? And we get information both by doing a biopsy, or in this case, removing the tumor through an inguinal orchiectomy, and also we get information by doing an RPLND. Secondly, we also want to improve the prognosis and specifically want to establish local control for these patients. The goal here is to excise the tumor with negative margins, either an R0 or an R1 excision, unless that would result in unacceptable loss of function or form as the general principle. Now, that's a big factor for vulvovaginal tumors, for bladder prostate rhabdos. In the case of a para-testicular rhabdo, in general, you have a contralateral normal testis. And so the unacceptable loss of function or form matters a little bit less here, although we'll talk about that a little bit more later on. And lastly, we want to make sure, of course, that we are increasing survival and decreasing the overall late effects of these tumors. So let's brush briefly on what exactly does the data show. And first, when you think about the data for para-testicular rhabdo in particular, you really have to be conscious of the fact that these are exceedingly rare tumors. So neuroblastomas, for example, are relatively easy to study. There are 750 of them per year. Wilms tumors, also relatively easy to study. You've got 500 per year. There's only 350 per year randomized sarcomas. Only 20% of those are genitourinary in origin. And so when you're specifically looking at para-testicular rhabdos, you only have 10 or 20 of these occurring in any given year in North America. And that relatively low frequency makes these things very challenging to study in any kind of data-based manner. So in terms of kind of what's out there currently, we know that historically 5-year event-free survival for rhabdo is greater than 85%, specifically for para-testicular rhabdo. But we did notice between the intergroup randomized sarcoma study group, third and fourth study, IRIS-3 and IRIS-4, an increased rate of retroperitoneal lymph node relapse. And that's primarily thought to be because these two studies differ in the way that they assess the retroperitoneal lymph nodes. In IRIS-3, everyone got an RPLND, primarily because CT scans at that time weren't good enough to adequately pick up and monitor and surveil the retroperitoneum. Therefore, everyone got surgery. In IRIS-4, CTs had advanced enough that actually cross-sectional imaging did have a role. And as such, there was a strong push towards imaging rather than surgical management and surgical assessment of the retroperitoneal lymph nodes. Interestingly, what this wound up showing was, again, a huge relapse rate or increase in relapses in the retroperitoneum in patients. And this is particularly true in patients who are over 10 years of age. PsyOps several years ago published their experience as well, and they found a very similar type of pattern where, again, shifting from a surgical assessment to an imaging-based assessment of the retroperitoneal nodes showed an increased relapse rate in patients over 10 years of age. And as a result, both in Europe and in North America, RPLND has been historically recommended for patients over the age of 10 years. And in fact, there's even some data from SEER to suggest that this is associated with a strong survival benefit. So what has the COG found when they've looked at this? Well, this paper was actually just published just a few weeks ago, actually, looking at 279 patients accrued over a multi-decade period, and 121 of those patients were over 10 years of age. Overall, most patients were low risk, most had negative resection margins, and most were N0 on original imaging. And as you can see here, survival was excellent. But only 21% of patients, despite long-standing, decades-long recommendations from RPLND, only 21% of patients who were over 10 years of age could be actually documented to have had an ipsilateral template RPLND, which at the time is what was recommended. We know that 29% of patients underwent a sampling of some kind. We know that 10% of patients underwent some kind of dissection, but a technique could not be defined based on the op node or the lack thereof. And a shocking 40% of patients actually had no node sampled whatsoever. And that SEER data that I mentioned before, this is a very similar pattern to what they found as well. Perhaps most tellingly, however, imaging alone would have missed 52% of patients who were later deemed to be node positive based on their RPLND pathology. Here you can see an overall attempt that we have had to assess whether or not there was a survival benefit. And although there was a trend towards survival benefits in patients who underwent a template RPLND, there simply weren't enough numbers to establish statistical significance here, with a p-value of 0.07. Lastly, we also then looked at some kind of retroperitoneal sampling versus template RPLND, and again, we were significantly hindered by the lack of data here. We therefore tried to look at, was there perhaps a cutoff where, for example, a certain number of nodes would make us able to say we had enough nodes to stop the dissection. There seemed to be an inflection point at around 7 nodes taken, and there was a second inflection point around 12 or 13 nodes. And so we therefore, in this paper, concluded that somewhere between 7 and 13 nodes seems to be the optimal number for harvesting when doing a template RPLND in these patients. So what do the experts say based on these data? Well, they're actually quite, turns out, in agreement. So the COG soft tissue sarcoma group has, again, studied this quite extensively, and they recommend an RPLND for patients who have N1 disease or those over the age of 10 years. PsyOp, when they've looked at this, recommend, again, N1 disease or patients over 10 years of age. And a recently formed consortium dedicated to attempting to study these in more of a database manner essentially came together and said patients who are N1 or patients who are older than 10 years of age and tumors greater than 5 centimeters, and patients who are optional, RPLND is optional for patients who are over 10 years of age and have tumors less than 5 centimeters. So again, the reality here is that most actually the current surgeons and current experts who have really looked at the data here are in agreement that patients over 10 years of age or patients who are node positive do need to have an RPLND. So lastly, I'll conclude briefly with what I do for my patients. And the simple reality is that having been raised in a robotic era, I'm quite frankly more comfortable with the robot. This technique was first described in 2006, and it was shown to have improved blood loss, improved length of stay, and a reduced risk of postoperative ileus. These are the typical ports I've used for using this in an SI. Since we upgraded our robotic system, I've actually not done a robotic RPLND. But this is what I would do for example, a right-sided template dissection. And this is actually a good example of a patient that was coming to see me for that right-sided template dissection. So you can see here, taking the spermatic cord on that side, opening up and getting into the retroperitoneum, going through and dissecting out and liberal use of clips, in order to actually make sure that we can get all of the node bundles out. And importantly, one thing that I will say is that since actually that data that I mentioned to you did come forward, I've actually stopped circumferentially mobilizing the great vessels because, again, you can typically get between 7 and 13 vessels, or excuse me, 7 and 13 nodes without actually harvesting and completely mobilizing the vessels. So in conclusion, para-testic rhabdo is a rare tumor with excellent outcomes. And although data are relatively sparse, the guidelines are relatively consistent. And that is that imaging alone is insufficient to detect positive nodes. Therefore, RPLND is recommended for patients who are over age 10 years and for patients who have N1 disease. And in general, a target of 7 to 13 retrograde nodes is recommended. And quite frankly, at the end of the day, the particular technique, whether you're doing an open technique, a sentinel lymph node biopsy, or a minimally invasive technique, is probably less important than making sure that you adequately get enough nodes and that you do go all the way up to the hilar vessels. Thank you very much. And with that, I'll turn that over to Dr. Granberg.
All right. I'd like to thank Dr. Ross and the program chairs for the opportunity to present. It's really an honor to present with the co-panelists, and it's really nice to have pediatric oncology on the agenda. So I'll be talking about the role of RPLND in adolescent testicular germ cell tumor. I have no relevant disclosures. So these are my objectives. We will be going through the NCCN guidelines, the surgical principles, and a couple of clinical trials. So the reason I'm leaning towards the NCCN guidelines rather than the AUA guidelines is, as you'll see, we're on the map as one of the member institutions. And this is just a great collaboration of tons of patient data that's been collected over time to really give us the best outcomes, to give us some data-driven decision-making. And realistically, the cure rates for this type of cancer are significantly high because of these sorts of collaborations. So for those interested, there is an app of the NCCN guidelines for providers that you can get on your phone. And there's a separate one for patients that if you're seeing somebody with testicular cancer, you can refer them to have this as well. So you've done the orchiectomy. It shows non-seminomatous germ cell tumor. Now what? Well, obviously you need to complete your staging, and just want to point out that a PET scan is not clinically indicated in the staging workup for this. It will not be able to differentiate between necrosis, teratoma, and viable germ cell tumor. You'll repeat the tumor markers so that you can get accurate TNM staging because it's based on the post-orchiectomy levels, and you'll follow those till they normal or plateau. Do you get a brain MRI? Yes, if there's an elevated HCG and AFP to the levels you can see here, extensive lung mets or non-pulmonary visceral mets are present, if there's choriocarcinoma in the specimen, or if the patient's exhibiting any neurologic symptoms. So you'll have your PT tumor staging based on your orchiectomy specimen. You'll combine that with the clinical end stage, your M stage, and your serum tumor marker levels. And together, that's going to give you your stage 4 prognosis. So once you get a prognostic stage group, that's when you'll enter into the NCCN guidelines to see what you're going to do. So the way I look at the NCCN guidelines for testicular cancer, because it's a packet about this thick, is I separate them into 3 groups. There's going to be stage 1, there's going to be stage 2A and B, and then there's everything else. So we're going to go through the recommendations, specifically looking at RPLND based on those 3 groups. So stage 1, if you have stage 1S, those patients are getting chemotherapy hands down. They have occult metastatic disease. So the rest of them, you're looking at risk factors first. And these are the risk factors that are listed: lymphovascular invasion, cord invasion, and scrotal invasion. Some will also add the embryonal component into this list. The NCCN guidelines doesn't recognize that because it really parallels the levels of lymphovascular invasion. So when you're looking at stage 1 disease, survival rates are exceedingly high no matter what you choose to do. So it can make it somewhat difficult what to choose. So if you choose surveillance for a stage 1 with no risk factors, that's great, but 20 to 30% of them will relapse. If you look at on the opposite side, you wouldn't want to overtreat 70 to 80% of patients. That's why we have 3 options. If you do choose to do an RPLND or primary chemotherapy, you should do it within 4 weeks of that staging CT scan. How about the group with risk factors? That becomes a choose your own adventure. This is where it's really important to have your multidisciplinary team so that you can discuss the side effects of therapy with the family and you have some patient-centered decision making. Moving on to stage 2A and B, really it depends on the markers. So if the markers are negative, you're looking at an RPLND in a couple of different situations. Markers negative, you can offer an upfront nerve-sparing RPLND. If it's negative markers and you have nodes that are within the drainage sites, you can offer it in select cases. If you do go with upfront chemotherapy, you'll obviously restage them, and then it depends on the markers and then the size of the mass. So if you have negative markers and a mass that's greater than a centimeter, those patients need a nerve-sparing bilateral template RPLND. Negative markers, no mass, or if the mass is smaller than a centimeter, again, this becomes tricky. You could do surveillance or you could offer surgery. And this is where you really see people kind of go toe-to-toe to try to determine what is the next best step. So maybe it depends on the pathology. So what would the pathology show if you did the RPLND post-chemo? It depends on the size of the mass that's left. If it's less than a centimeter, you're looking at about 71% necrosis, 24% teratoma, and 4% viable germ cell tumor. Now, this was a meta-analysis of 588 patients. I don't know where the other 1% went. So for those of you doing the math at home, they did not specify. That ends up to 99. If it's greater than a centimeter, 50% of them are going to have either teratoma or viable germ cell tumor. And that might lead you towards your decision making. And why is that important? Because teratoma is really unpredictable. The PET scan, again, is not going to differentiate teratoma from necrosis. You could have growing teratoma syndrome, and I've seen these grows to the size of a watermelon that really starts to take over the small bowel mesentery, invade surrounding organs, and makes it a really difficult resection. These are chemoresistant. Nothing's going to touch it. And there's always the risk of malignant transformation. And if there is a late relapse, their survival goes down significantly. So for that everybody else group, and they all got upfront chemotherapy, when are we looking at RPLND for that group? If they have a complete response, negative markers, again, you're looking at surveillance or an RPLND. If they had a partial response with a residual mass, but normal levels, RPLND. Partial response, residual mass, but only slightly elevated markers, you can consider an RPLND. And if they had a late relapse, then they're a candidate as well. So we'll talk about the surgical principles of the surgery. For both primary and post-chemotherapy patients, the NCCN guideline recommends referral to a high-volume center with experience in performing RPLNDs. That should be considered. Well, how do you define that? That's really difficult to know what are people's numbers and what defines an experienced team. So a self-definition is to have a multidisciplinary AYA cancer team, both from an oncology standpoint as well as a surgical standpoint. And on the urology surgical standpoint, my colleagues would state that you should have an SUO fellowship-trained uro-oncology surgeon at the table. They do way more of these than most pediatric urologists ever will. So again, technique is super important, and we will get to that. The principles itself haven't changed much. We still utilize the split and roll technique where you're identifying all the lumbar vessels, ligating them all the way down, resecting all of the lymphatic tissue around and behind the aorta and vena cava. So here's a huge post-chemo mass that's left over. Again, negative markers. This is an intra-op photo, and one of my colleagues will state that you should be able to lick the surface of the anterior spinous ligament. It should be that clean. And so that's the type of dissection you're looking at. Again, this was a non-nerve sparing approach. And when you talk about unilateral versus bilateral template, if you're looking at a stage 1 primary RPLND, a bilateral template approach is really what most of the high volume surgeons are looking at. And we'll talk about why in a minute. So the nerve sparing approach is to maintain the trifecta. And you can see how beautiful these nerves are right here. If you preserve the sympathetic chain, postganglionic nerves, and the hypogastric plexus, you'll preserve antegrade ejaculation in over 95% of patients. So the template you can see in the upper right-hand corner of your screen, and this is just a Penfield dissector. This is a favorite tool of Dr. Borjan, who's one of my colleagues. It really helps to elevate tissue off of the anterior spinous ligament, and you can really peel the tissue away from the nerves as well in a nerve-sparing approach. He also says you should be able to floss the great vessels. Well, what does that mean? You should really be able to get your hands behind both the aorta and vena cava and between the two. And that's a true complete dissection. So it's a little different than what we just heard about paratesticular rhabdomyosarcoma. So it's not just a sampling, it is a dissection. You really need to get everything within the template. So why not a modified template dissection? So the risk of contralateral retroperitoneal mets has been reported in up to a third of patients. And so you're going to miss that in some of these kids. And you'll have a high rate of preserving ejaculation if you use a nerve-sparing approach, both in primary and in post-chemo situations. So when you're looking at the surgical principles here along the left, you'll see this is from the NCCN. The completeness of resection is a consistent, independent predictor of clinical outcome. Margins should not be compromised just to preserve ejaculation, and additional procedures of taking out additional structures may be required to get margins. So what I always say here is you really got to load the boat. This is not something that just a pediatric urologist should be doing once or twice a year. If you want to have good outcomes, you should involve your GU oncologist. There's some cases we have to have a vascular surgeon. We have to have a hepatobiliary surgeon because we're really taking a whole bunch of things out, and you want to have the right people at the table. Minimally invasive, we heard a little bit about this from John. It's kind of similar for germ cell tumor. There's really small series out there for this group. Is it feasible? Yes, but there's limited data. There's increased frequency of in-field recurrences and aberrant recurrences, and chemo won't rescue those. So the NCCN doesn't recommend it. If you have a high volume surgeon that you want to refer to that does it, then fantastic. They should be the ones doing it. Again, you can go toe-to-toe with the big cancer meetings on open versus minimally invasive on this. 2 clinical trials I want to highlight. There's a COG accelerated protocol for BEP. It's every 2 versus every 3 weeks for intermediate and poor risk cancer. Again, I'm talking about RPLND today, so this does eventually lead to surgery, and this encompasses our pediatric patients age 11 to 45. Another one, RPLND for stage 1 to 2A seminoma. Seminoma, I know this is sacrilegious. When I was training, you would never put RPLND and seminoma in the same sentence, but there is a phase 2 trial that's active but not recruiting, 16 and up, and we're talking about 1 to 3 centimeter masses as a primary approach. Again, this is to avoid the long-term effects of chemotherapy and radiation. You can have scatter effects, cardiotoxicity, secondary malignancies. So again, they're looking for recurrence-free survival and complications. So take-home points, follow the guidelines. If there's a mass there, take it out. If there's no mass, they have options. Teratoma is unpredictable. The surgery should be done at a high-volume center. You need a multidisciplinary team, and really the best management for a patient with cancer is a clinical trial. Thank you. I'll hand it over to Amanda next.
All right, so thank you so much for inviting me to be part of this tumor board today. We know, as Dr. Granberg said, that most testicular masses in adults are malignant and managed really with radical orchiectomy. That's the standard. But in children, about 75% of the testicular masses are benign. And so partial orchiectomy has become an acceptable alternative to minimize the removal of gonadal tissue. And just a word on nomenclature, partial orchiectomy is the same as testis sparing or testicular sparing surgery. And this is essentially an excisional biopsy via an inguinal incision. So the approach to a testis mass in any patient that we would see in our practice is really dictated by 2 factors. Number 1, the suspicion for malignancy, and number 2, the desire for and the need for hormonal preservation. You have several clues preoperatively that can guide you to determining what you need to do for the patient. And the 2 that I'm going to focus on today are pubertal status and tumor markers. So there was an article written by Dr. Wu and Dr. Ross just this past year in the AUA Update series that was really, really good and really highlights some of the differences between pre and post-pubertal masses. We already went over the malignant potential, but if you look at the type of malignancy in prepubertal patients, this is usually a pure yolk sac tumor or potentially a pure teratoma, whereas post-pubertally, this is a mixed tumor. Metastatic potential, post-pubertal patients have a much, much higher rate of metastasis at presentation. And then there's a word on teratoma. So a teratoma in the prepubertal patient is usually pure and behaves in a benign manner, whereas post-pubertally, this is usually part of a mixed tumor and is prone to malignant degeneration. So we have our traditional serum tumor markers, AFP. This is secreted by about 90% of yolk sac tumors and some non-seminomas. And we have to remember that there's a physiologic elevation in infancy that needs to be accounted for. Beta HCG can be elevated in some non-seminomas and a few seminomas, but it's very, very rarely elevated in prepubertal patients. And then LDH is really a sign of bulk disease. Importantly, you can't make and you shouldn't make treatment decisions based on this alone. So the patient shouldn't be S1 or S2 based on LDH alone, and their risk assessment, if they're metastatic, shouldn't be made on LDH alone. Then we have some other tumor markers that can be useful for stromal tumors, such as inhibin, testosterone, and estradiol. So this is work actually published by Dr. Ross several years ago that looked at AFP levels. So you have the age of the patient on the x-axis in weeks, and then AFP levels on the y. And what you can see is there's a rapid decrease in the first 4 weeks of life. And then moving on, we've got age in months on the x now. Really, the levels return to almost normal around 6 months. And so the reason that's important is after 6 months, what we see is that all the yolk sac tumors that were found, those are in the dark circles, all of them had an AFP greater than 100, whereas all the teratomas had an AFP less than 100. So this can be something useful clinically when making decisions on how to approach a patient. So who should have testicular sparing surgery in the prepubertal patient? Obviously, normal HCG and age-appropriate AFP, no known metastatic disease, and really any surrounding normal parenchyma. It doesn't have to be a lot, anything is okay. And I would argue that almost every prepubertal patient that meets these criteria can have an attempt at testicular sparing surgery as long as you use intraoperative frozen section and you can convert to a radical orchiectomy based on that. So now we get to the controversial part, testicular sparing surgery in teens and young adults. So like I said, radical orchiectomy is definitely the standard of care for all testicular cancers. And the AUA guideline that we previously heard a little bit about really has two components that are relevant to pediatric urologists. Number one, that postpubertal patients should be treated per adult algorithms, and that partial orchiectomy is really only recommended in certain scenarios like a solitary testis or bilateral tumors. So the German Testicular Cancer Study Group several years ago looked at testicular sparing surgery in select situations listed below. So these are adult patients, small masses, normal markers, and these patients receive adjuvant radiation if there is germ cell neoplasia present. So a quick word on this 2 centimeter size cutoff. We know in adults that tumors less than 2 centimeters in size have a 15 to 20% chance of malignancy, so pretty low. And this was confirmed in a recent Italian multi-center study just published a few months ago in JU. And this did include some patients as young as 11 and confirmed that the small masses are often benign. And they recommended this stepwise approach of a partial orchiectomy, frozen section intraoperatively, and then either completion partial orchiectomy or radical orchiectomy based on this frozen section result. Now, some work that Dr. Brian Caldwell and the group in Colorado did it makes it a little bit questionable if this 2 centimeter size cutoff is applicable to pediatric patients only. And they had a very small review of 24 patients, but everyone was under 18. And they didn't find that the 2 centimeter cutoff accurately predicted pathology, but frozen section did. So they suggest that testis sparing surgery should be offered regardless of size, as long as there are tumor markers, and intraoperative frozen section should be used. So again, going back to this German Testicular Cancer Study Group, at 7 years of follow-up, their outcomes, the vast majority were no evidence of disease, most had preserved testosterone, and half achieved pregnancy without assisted reproductive technologies, which is really good news. Some technical aspects on testis sparing surgery. So as I said before, you need to be prepared to convert to radical orchiectomy if necessary. So this means an inguinal incision, high control of the cord, and avoiding any scrotal violation. Use intraoperative ultrasound. This may help you locate the lesion and locate and be able to get good margins on the lesion as well to ensure complete excision. I can't emphasize frozen section enough. This is very, very highly correlated with final pathology, and this really can guide your intraoperative decision making. Importantly, when you're doing a partial orchiectomy, you have to sample adjacent tissue. You need to look for surrounding germ cell neoplasia in situ, and this may help you determine pubertal status if you're confused about that at all, which certainly can happen. So a word on cold ischemia. So this was initially used in the reports by the German Testicular Cancer Group. And what they did is they clamped the cord and then placed the testis in ice while the frozen section happened. And that was because they knew that Sertoli cells showed damage after half an hour of warm ischemia. Now, the group from Duke looked at a prepubertal rat model that compared 30 minutes of warm and cold ischemia. And then when they sacrificed the rats at puberty, they didn't find any difference in testosterone levels or sperm counts. But actually, there were more histologic differences in the cold ischemia group. Now, there's no studies done in humans that I'm aware of, so really the best practice is unknown. All right, now we'll talk about cord occlusion. So cord occlusion definitely helps with hemostasis, but you only need this really when you're enucleating and repairing your defect. Early in urology training, we are taught that you must clamp the cord early to avoid seeding and spillage of the tumor. But when I've looked this up, there's no evidence that this actually occurs or that it has any effect on oncologic outcomes. And what we know about testicular cancer and several other malignancies is that spread and seeding is probably much more related to molecular changes on the cellular level than manipulation alone. So what I try to do is balance the cord occlusion and the need for hemostasis during excision and repair of the testis, and then releasing the tourniquet to allow maximal perfusion of the remaining parenchyma while I wait for my frozen section to result. So key take-home messages. Pubertal status really guides your risk of malignancy. And this is the most important element when you're considering approaching a testis mass with testis-sparing surgery or a radical orchiectomy. The majority of prepubertal masses can be managed by testis-sparing surgery, but really careful consideration should be given for postpubertal patients as this has been demonstrated to be safe. Tumor markers must be normal to consider partial orchiectomy. You have to be prepared to convert to a radical orchiectomy based on intraoperative frozen section results. So you have to use an inguinal incision and then use your frozen section. I can't emphasize this enough to guide your intraoperative decision-making. Thank you so much.
Thank you, guys. Those were awesome. All right, can you guys see all that? Can you see that? No. Uh-oh. Am I back, guys? Am I back yet? Okay, am I back, folks? Can you guys hear me? Can I get a thumbs up from someone?
Yes.
Yes, I'm ready now. I had actually, somehow my my computer kicked me off of Zoom there for a minute, so I had to come back to Zoom. So I apologize for that, everybody. So you guys can see now my case one, and you can hear me. Yes? All right, so I'm going to stop share. I'm going to share screen. Is that any better? Okay, good. All right, sorry about that, guys. That's what happens when you put a boomer on at the end of the day as a moderator. So the next section is going to be case presentations and questions. What I'll kind of do, I'll try to multitask here and look over at the questions as we go through. We'll run the cases. If I see there are questions coming in, we may break the cases for a minute to ask a question that's relevant to the cases, or stop the cases at some point to just go through the questions. If we don't have questions coming through, we'll just continue with the cases, and I sort of have questions related to each case as we go. So the first case is from Richard Lee's group, and James, actually, the first author, was kind enough to send me the images and so forth. And I'll call on the panelists to sort of respond and give everyone a chance to answer, so we try to keep from talking over each other. But this is a 15-year-old with 2 months of scrotal swelling and weight loss. And you can see that there's a retroperitoneal node. I think it was about 1.1 centimeters, so not a very big node. So, and did the orchiectomy. It was a rhabdomyosarcoma. So you have a 15-year-old with a rhabdomyosarcoma and a positive lymph node. And so we'll throw this one first to John. I think you covered this, and so we'll see, sort of reinforce what you said with this case. With the lymph node on the CT scan, what would you do? Would you do a modified template RPLND, something else? And John, I'm going to let you respond to that, and then we'll get input from the others.
So in my mind, this one is to a certain extent kind of a no-brainer. He's over 10 years old, and he has N1 disease based on that CT scan. And so actually all groups would, in this case, recommend going ahead with a RPLND. And again, there's a bit of controversy, or at least discussion, in regards to what kind of RPLND you want to do. Historically, a modified template RPLND was what's recommended. In fact, in the current randomized protocols, that is what is recommended. But based on this newer data, in my hands, I would want to do that robotically, simply because you can go in and do a good dissection with a good node count. You can clean out that one area that you're seeing there relatively easily. Again, I personally do not mobilize the gray vessels, simply because there's not necessarily a survival advantage that we've been able to define based on the COG data. SEER data would suggest that there may be a survival advantage that's there. So I don't think you'd be wrong by any stretch of imagination to do a true bilateral template RPLND in this particular patient. But the French and Italian series, for example, would suggest there is going to be some sexual side effects that are there. And knowing that that this patient is going to benefit primarily from cleaning out that area, in my personal recommendation or my personal belief, I would go with the robotic unilateral RPLND, get that one node, and call it a day.
Why don't we go to Candace and then Amanda, just if you feel any differently or want to amplify on that.
I second John, 100%.
Yeah, I would do the same thing. I'd probably approach it open, to be honest. And one thing I think that is worth saying is that I would definitely talk to the family about sperm banking before this, just in case there were issues with my nerve spare.
And John, this is something I've sort of been uncertain about. If there's obvious nodes in a kid with paratesticular rhabdo, and the only goal here is to confirm positive nodes so that you know that you do indeed need to give radiation, why wouldn't you just take out a couple of the obvious nodes, get a frozen section so you're sure you got something, and not put them through a bigger modified template RPLND? Or is there evidence that there's actually therapeutic benefit to the RPLND in those cases?
That's a great question. The short answer is that, as I mentioned, it's a rare tumor, and the data that's out there, even the data that we just compiled from COG, is messy. And so, in the COG series, it approached a survival benefit that was statistically significant, but didn't quite get there. The SEER data that Mary Austin and her group published a few years ago would suggest that there is a survival benefit. And quite frankly, that discrepancy in the data that's out there is what leads some people to recommend doing a sentinel lymph node biopsy and calling it a day, as you mentioned, just kind of doing a cherry-picking RPLND. With the current data that's out there, I don't think that is necessarily the wrong answer. But again, my strong suspicion is that if we had more patients in the COG study, we probably would have hit statistical significance. That's wishful thinking, perhaps, on my part. But to my mind, again, in my hands, I would want to go ahead and take out as many nodes where they're already there.
So it's not just that you need a certain number of nodes to be sure that you got enough to rule out positive nodes. You think there's some therapeutic benefit. So even in the face of some obvious nodes, it may be worth cleaning things out better.
That's what the SEER data would suggest, and what the COG data would suggest might be the case. But again, that's with a big caveat and a big asterisk.
Okay. And if the CT was negative, I think you answered this, you would again do a modified template RPLND. Obviously, if they're less than 10, you wouldn't do anything.
Exactly.
And this was, as I said, from Rich's group. Is actually a report that's been published of 2 cases, and they did radical orchiectomy. They did a robot nerve-sparing RPLND, found 2 of 43 positive nodes. The patient got X-ray therapy, got chemotherapy, and then after the RPLND and during the chemotherapy, had no erectile dysfunction, but did have loss of antegrade ejaculation, to your point. And then eventually, though, by I think it was a year after therapy, so maybe 18 months after everything, after the RPLND, in both the cases that they reported, the antegrade ejaculation returned. And there's some question, I assume, between how much the RPLND is playing a role, how much the other adjuvant therapy may play a role in some of this. But it sounds like these are cases where you guys would all recommend sperm banking for patients who are old enough to do so. Is that fair?
Yeah, Amanda raised a great point, and I could not agree more. Sperm banking is crucial in these patients. All
right. let's go on to case 2. This is actually a case that Amanda sent in from the University of Kentucky, but it's a case on Candace's topic. So I'll present the case, we'll ask the questions to Candace, then John can make some comments, and then Amanda can tell us what really happened with the case and what I got wrong in presenting it. So this is case 2. You can see here's a normal left testicle. This is the right testicle. It's a 15-year-old who has a testicular mass, had previously had an orchidopexy for an undescended testicle. But the testicle is now scrotal, as I understand it. Had this testicular mass, and you can see he had a fairly sizable retroperitoneal adenopathy, and the markers are listed here. Had lung mets as well. And so the patient underwent an orchiectomy, which showed a mixed germ cell tumor, primarily embryonal, with positive lymphovascular invasion, positive spermatic cord invasion, positive margin. So you can see the staging here. The patient got chemotherapy and then has this. And I skipped over a lot of the earlier parts of the case because I used this one as an example of what to do with a retroperitoneal mass post-chemotherapy. So now there's a 4-centimeter residual mass. The lungs are clear. The markers are negative. So what would you do now? And we'll ask Candace to address that first.
Yeah, so I think, there's a lot of risk factors, present on the pathology specimen with a high percentage of embryonal and the lymphovascular invasion. Having elevated markers that came down is great, but this is a sizable mass, with residual disease. And this kid needs an RPLND. And this would be, a bilateral template. You can try to spare the nerves as best you can. Post-chemo, it's kind of tough. But again, this is why I do these along with my partner who does these every single week. He's doing at least 1, if not 2, RPLNDs. And so, this sort of a patient is at high risk of having, even some teratoma in the specimen that may not, show up on the next couple of scans if they were just being followed. I think a big concern we have with a lot of these young guys is they might get lost to follow-up. And so we look at the social situation. Are they coming to their appointments or not? If they're a flight risk of not being compliant with anything, we're really making sure we follow them closely. So this is definitely residual mass, and he'd have a bilateral template or RPLND in our hands.
Yeah, I think we would do the same. Amanda and John, would you do anything different? No, okay.
No, actually I would do exactly the same thing.
And let me ask you, Candace, I have read some papers that, you talked about the 1 centimeter cutoff.
Mm-hmm.
I've read some papers that say even if there's nothing on the CT scan after chemo, maybe you should do an RPLND again for, I think, some of the reasons you talked about with teratoma and so forth. What are your thoughts about that?
Yeah, so that's exactly why, we talk again about the social situation. Are they going to lose their health insurance by the end of the year? And all of a sudden you're looking at, they're going to miss out on these scans. And so the guys with absolutely no disease on CT, looking at the risk factors in the specimen, we certainly would offer an upfront RPLND. I mean, they're going to get, 1 post-op CT scan, and that's it if they had negative nodes, which is great. And all of a sudden you're saving them from the secondary malignancy risk. And, it can be a one and done. Yes, it's a big surgery, but we have, our advanced post-op protocols now that have, speed to, walking, pain control, diet, that they're really in the hospital for maybe 2 nights, at most 3. So, that's a small investment into long-term cure, and we'd certainly offer that up front. But it's always a discussion between our GU oncologist, the urologist, and the family, because we're obviously taking care of kids and teenagers, but making that decision together is super important. I think sometimes the pediatric oncologist at a standalone children's hospital may not be as up to date on all of the controversy that's there with that size of a mass, the less than 1 centimeter, or a complete, absence of anything within the retroperitoneum, to say, let's just put them in this category. But we certainly would offer it here. It's a big controversy that they love talking about at the big cancer meetings as well.
And Amanda, I should give you a chance if there was anything, any other points that you thought were important from that case, or anything that you wanted to add, since that was actually your case.
No, I think actually what Dr. Gramberg really hit it on the head, that this was referred to pediatric oncology, and there was a lot of back and forth on what we should do in this situation, following either COG guidelines versus NCCN guidelines. Ultimately, he got a full bilateral, no nerve spare RPLND.
Okay.
So.
All right. Let's move on to case 3. This comes from Karen Pasui at the University of Manitoba. And this one sort of fits in with Amanda's topic. So this is a 13-year-old, and you actually brought up this issue a little bit. We'll talk about it a little more, with right scrotal pain and a large testicle. It's a little bit of a complicated case because there were multiple tumors. It wasn't clear if there were 3 separate tumors or there was sort of lobulated tumor. And you can see on some of the images, there's some features that suggest epidermoid cysts, and I think that was sort of the thought about the most likely diagnosis at the time. They went ahead and did testis-sparing surgery, excised them. They were all very close to each other, so it took them out as one mass. One of them was a little fixed to the tunica albuginea, but they took them all off for frozen section. They got random samples of the surrounding tissue as well. And the frozen section actually said it's not epidermoid cyst. It's actually looks like it's mature teratoma. So you have a 10 or 2 12-year-old. You've done this testis sparing. It's a mature teratoma. Now what? As you mentioned, mature teratoma is benign prepubertal, but can be malignant postpubertal. So the first question is, in the operating room, do you go ahead and remove the testicle, or do you sit tight?
So I've thought a lot about this. I luckily haven't faced the situation myself yet. But here, if I was at all concerned about that, I would want to have a discussion with my pediatric oncologist first, because I want to make sure that they are on board with whatever we do in the operating room. I think it also depends on what his other testicle looks like. Does he have another one? Is it normal in size, etc.? And really discussing with the family that, standard of care, if we are treating this as conservatively as possible, that he was post-pubertal, would be a radical orchiectomy. But, really trying to load the boat before I make that decision. And I would also ask my pathologist to tell me if there's any spermatogenesis in the specimen, to try to give me a little bit more evidence of whether or not he's sort of pre or post-pubertal. But this is a really tough situation.
I think this is probably the kind of case where you would, going into it, this could be the outcome. So you probably would maybe talk to the parents ahead of time about the option of removing the testicle or not, and make a sort of shared decision with them about what to do. In this case, the testicle was left in situ. So they did do testis sparing, left the testicle. The final pathology was mature cystic teratoma. They did ask if there were signs of puberty, and got this sort of response that, well, they don't see sperm, but it's not a totally quiescent prepubertal testis. And I think I'm a little guilty here, because I've certainly put in my papers that you should look at the surrounding testicular tissue and does it look like mature testicle or not. And their pathologist made the point that really looking at things like testosterone, testicular size, Tanner stage may be more accurate. So unfortunately, Tanner 2 is sort of equivocal as well. So the question was then at this point what to do. Do you go back and take out the testicle? Do you do metastatic evaluation? What sort of follow-up would you recommend? So what do you think about that?
I really think, you could split this either way. I personally would be worried about not treating him as a post-pubertal patient, because that's really where you can lose. So I would definitely do a metastatic evaluation, and I would try to follow him up very closely.
Yeah. Candace or John, do you have any other thoughts on that?
I'll weigh in on the completion orchiectomy. I'd also just keep an eye on it. I think that's why we have ultrasounds. They're great at looking at testicles, and it's easy enough to get one anywhere. If he lives far away, you can look at it remotely, do a telemedicine visit, and make sure you're following up on that. And he can do self-exams for any new lumps or bumps in the meantime on the interims. I would get a metastatic evaluation just to make sure there's not something occult back there. And then depending on what you're finding, then try to get a follow-up plan together.
And likewise, sorry.
No, go ahead, John.
I was just going to say the only thing that I would toss out is how true this is and how much of this is surgical folklore is tough to estimate. But the concept that if you do the CT scan prior to doing the surgery, then you may avoid inflammatory lymph nodes showing up, and then you really get stuck into a conundrum. That'd be the only other thing that I would toss out, is ideally getting the CT scan ahead of time would be nice.
Yeah, that's a very good thought. I'm going to go to, we have a couple of questions, so I'm going to go to these questions here. one of the questions is, during the testicular sparing surgery, how far do you continue for sampling if the frozen is positive, or do you directly go to orchiectomy after a positive frozen? So I assume, so it is definitely a enucleation. It's not an incisional biopsy. So if it shows that, yeah, that looks like yolk sac tumor, then do you mess around anymore, or do you just go ahead and take the testicle out?
No, I think at that point you take the testicle out. I mean, if there's a malignancy, the standard for cancer is to do a radical orchiectomy.
I think we probably all agree with that, that if it looks like there's yolk sac tumor there, then the testicle comes out. Another question here, please explain about the testis preserving surgery and the risk of immunologic contralateral damage to the other testis.
Yeah, that's a good question. There are some reports of that. And I think, obviously these are generally prepubertal patients, so you couldn't usually do sperm banking as a standard, although that is something that's experimental at that time and right now at several institutions in the United States. I think you need to be upfront with your patients and families and say that this is something that has been reported. But I think the idea of making sure that you can preserve enough hormonal function for the future is very important.
Yeah, I wonder if part of the stimulus to that question was sort of the issues in torsion about once you've sort of gone into a testicle, then does that give you anti-sperm antibodies and potential issues with fertility? And I frankly never really worried about that much with torsion anyway. I wasn't convinced by the literature on that. But I wonder if that's sort of where that comes from. All right, we're going to go on to the next topic, and this is something we haven't really talked about yet, so I think it would be helpful. We sort of talked about teratoma, prepubertal and postpubertal, but we haven't really talked about stromal tumors. And this is a case from Mark Colasso and Janelle Fox that's sent to us from UPMC. And this was a 17-year-old with 4 to 5 centimeter heterogeneous appearing mass. The CT and tumor markers are negative. And so underwent a radical orchiectomy based on the age and the appearance of the mass. They didn't really consider testis sparing at that point. And it's a Sertoli cell tumor. And you can see it's sort of it's a large one, but otherwise it's limited to testis. There's nothing bad, no LVI, no positive margins, no germ cell neoplasia. And so it sort of brings us to the whole issue of, the stromal tumors and, can you treat them as a benign thing? Do you need to worry to some extent? And maybe we'll start with Candace. We'll give you a chance to go first on this one. What your thoughts would be. How concerned would you be about this case?
Yeah, I mean, I think he has a lot of things going for him here with the complete resection and no lymphovascular invasion, limited the testis. So a T1 tumor is a good thing. And when we talk about Sertoli and Leydig cell tumors, the likelihood of having a malignancy is so exquisitely low. In prepubertal patients, it's a little bit different. This guy's 17. Our adult colleagues here tend to do, the metastatic workup and then just see, as long as there's nothing there, are willing to follow. If there's any question on the pathology, I think getting a second opinion on path is super important. Sometimes we'll see second opinion paths sent here just through our GU pathologists, and they end up having granulosa cell tumor variant. And now you're talking about, do they have a Dicer 1 variant that we're looking at, screening for other malignancies and giving some information towards family members and screening. So if it's an isolated Sertoli cell tumor, the likelihood of metastatic disease is so exquisitely low that it would be a tough sell to do an RPLND if you had a negative CT scan. And here it seems that our GU oncologist on the adult side, because he's 17, so he's right on the border, if they would see him, they'd recommend getting a staging workup just to be sure. And if everything's negative, really just keep an eye on him, do self-exams of the other testicle, and then watch out for any symptoms. There's always the risk of over-treating and over-screening. And if we're looking at cost benefit, it would really be costly to continue doing CT scans and markers and chest x-rays if the first one is negative.
Yeah, John, what do you think of that?
I actually completely agree. I would also just keep an eye on it, and I would be very reticent to do anything more in this particular situation, given that path report.
Yeah. Amanda, do you feel any differently?
No, I completely agree.
And I think Janelle was kind enough to send a literature review, a slide of sort of the literature review they had done. And here's a meta-analysis that was done that pretty much agrees with you guys, that looking at least in what's out there in the literature, and there's not a ton, that, sort of low impact surveillance, don't do the RPLND unless there's something weird going on. to sort of follow these. We have just a little bit of time left, so I'm going to ask one question and then we'll be done. How do you guys manage the issue with the COG protocol? Well, let me ask a different question. I had a patient who had a teratoma, prepubertal patient, teratoma, did a testis-sparing surgery. The final path showed a small focus of yolk sac tumor in the teratoma, which was not apparent on the frozen section. And I think that probably happens not terribly infrequently. And I don't think of that really as a mixed germ cell tumor. But let's go to Candace. We'll let you tackle that one. What would you do about that?
Sure. How old did you say the patient was?
It was a 3-year-old.
3-year-old. So still in that really low likelihood of having metastatic disease. I think it's hard when we get something that's different than the frozen section path. It's hard to face the parents because now you're telling them something different. So that's always the first battle. And again, the testis sparing portion of it is fantastic, again, because he's got a testicle that's descended you can follow with ultrasound. So I wouldn't necessarily go back and do a completion orchiectomy on him as long as markers are where they need to be. I would do a staging workup and then just follow. It's tricky because there might be a group of pediatric oncologists where one says, this is the book, this is the Bible, this is what we're doing. And there's some that say, let's think outside the box and not radiate this poor child. And I think if his markers were completely negative and his first set of scans were negative, I would just follow him with scrotal ultrasound and be a little less aggressive.
Yeah, that's what we did. I figured I got a lot of AFPs involved because that's easy.
Yeah.
And then I think I probably did 1 or 2 more CTs at some intervals just to reassure, and he was totally fine. Well, our time is up. I really appreciate you guys participating, and I really appreciate the audience staying till the bitter end here and staying engaged. I've really enjoyed the conversation, and I'm going to turn it over to Dr. Braga to close out the meeting.